Thank you. All right, so this is a med-surg case study, next generation style respiratory, and Erica is in the lead walking us through. And so you were talking about the lab values, Erica.
Yeah, so we've got our pH is 7.2, so we already know she's acidotic. PO2 is 75, low borderline, we're in there. PCO2 is 51, so we know that that's also acidotic, and we know it's respiratory acidosis because we're on that side. HCO3 is 28. Okay, she's compensating a little bit because that's alkalotic. White blood cell count is 35, slightly low. Platelets are right in the middle, we're fine. Serum potassium is okay, serum sodium's okay, magnesium's okay. Her lactate level is elevated, negative for gram-negative COSI, and everything else is pending. Okay.
Okay, fantastic. Thanks for walking us through that, Erica. Okay, and so I'm now going to shrink it down so you can kind of see everything in one page here. And you can continue on if you like, Erica.
Okay, which 4 findings are most urgent? So we're gonna go ahead and pull out the pH of 7.2. We're gonna pull out the respiratory rate of 30, that's absolute. We're gonna go ahead and pull out, let me look, the pulse ox of 87. And we're gonna pull out the PCO2 of 50.
Okay, fantastic. I'm going to pause here and I'm going to ask, does anybody disagree with this, or do you think something else should be selected as far as the findings that are the most urgent based on this patient's condition right now? Or maybe you have a question as to why Erica chose what she chose. Or maybe you're thinking, yeah, I would have chosen the same things. What do you all think?
I would have chosen the same 4 things.
Okay, so Ethan says he would have chose the same. Okay. And I know we have a mixed group here because there are some Med-Surg 1 students. So maybe they're like, man, I'm not really sure because I don't feel comfortable with this information yet. And that's okay too. So anybody else have any comments about this? Okay, so Kathy said she would have chosen the same. And so Erica actually did choose all the right choices. Okay, I'm going to put the rationale in the chat. And it seems that I think many of you are on the right track. And so when we talk about the 4 findings that are most urgent, if you could address 4 things and you had to go home, what would those things be? What I like about these questions is that they have the reference ranges here. And so that kind of tells you anything that's abnormal, I'm going to put a little star by it. And then I'm going to prioritize the things that are abnormal or not in, normal range. Okay. All right. Anybody have any questions about question number 1 or any comments?
No.
Okay. Well, let's go to question number 2 then. So with these questions, you want to always look to see if there's any new notes, any new lab reports, any new orders, anything that's new, because you don't want to just skim over it and then miss new information, because that will actually help you as you're making your answer choices. Now for this one, there's nothing new for question number 2, and we're going to have Erica continue if she doesn't mind for question number 2.
Okay, so for each finding, click to indicate if the finding is consistent with acute respiratory failure or pneumonia. Each finding may support more than one condition. Each column must have at least one option selected. Cool. So crackles, bilateral lower lobes, that can be acute respiratory failure, but also pneumonia. That's kind of hugely indicative of pneumonia. She doesn't have a fever though. Pulse
Okay.
ox of 87, that would also be both. That could be normal with both. Okay, here's where it's going to be different. Acute respiratory failure, I would check for the CO2 of 51 and the pH of 7.2 because the body is not compensating. That's why you're in respiratory failure. Now, pneumonia, you shouldn't have any ABG issues really.
Okay, and you're right.
I wouldn't check those with that, no.
Okay, and you're absolutely right. Okay, so with these So this is testing. Do you know the clinical cues, the signs and symptoms of acute respiratory failure versus pneumonia? And for the Med Surg 2 students, your test is going to be on this. Okay, so you need to know the clinical cues, the signs and symptoms of respiratory failure versus pneumonia versus asthma versus, okay, what's crackles, what's wheezing. So you need to really know that. And if you're not sure, definitely look it up. But this was a great question, and I like how Erica broke it down to say, okay, we're not having ABG issues, but these are the things that we expect to see in a particular medical diagnosis. Okay, any questions about this question?
I will say, I feel like the pneumonia could have caused the respiratory failure if it had gone untreated. That makes sense, but we've
Mhm.
already progressed past that. We're worried now about her breathing. She's already on 100% oxygen.
Right, absolutely. So, and this is a critical patient, right? This is a very, very sick patient, high acuity patient. And, you know, a lot of times your pneumonia patients, they're sick, but they're not, you know, okay, ICU level sick sometimes, right? So yes, but acute respiratory failure is an ICU high level, okay, we're concerned about this patient not surviving kind of scenario. Okay, all right, great. All right, let's go to question 3. And again, I'm scanning to see if there's any new nurses notes, any new lab data, and it looks like everything is still the same. So I'm going to go to the question and I'll turn it over for Erica.
So, what's the nurse determine as the priority for this client's care? Um, we're past the point of treating things. I mean, we're going to treat, but we're thinking we need to set up for intubation. As a nurse, that needs to be our thought process. We're going to set up for endotracheal intubation. After that, they're probably going to treat her with antibiotics. They're going to need to get an X-ray and stuff. We're going to probably have to the doctor will consider sedation, but very first thing, they're going to go ahead and RSI this patient and intubate this patient.
Okay, hold on. You used the term RSI. What is RSI? Oh, hold on. You're muted, Erica. Sorry.
um, Rapid sequence induction or intubation. You give a series of drugs. I use 2 right now. The hospital usually uses 2, and a nurse is going to be responsible for pulling up those drugs, a paralytic and a sedative. You're basically going to paralyze the patient's breathing so that you can get this tube down their throat to ventilate them. So you're going to have to get all your stuff ready for intubation. And usually it's on the code cart, your bougie, your ET tube, your 10 cc syringe, you know, their blades, they're going to have a Mac or a Miller. And then you're also going to have to get your bag valve mask ready, hooked up to 100% oxygen. And then someone else, another nurse is going to be responsible, or whoever, the doctor, you know, for pulling up the sucks or the etomidate or, you know, the rock or whatever they're going to use. And every hospital has their own protocols for that.
Okay, gotcha. So let me ask you something because you mentioned a lot of great things, but why is it necessary to sedate the patient prior to intubation, and why is it necessary that we want to paralyze, you know, the respiratory system prior to this intubation?
So we need this to go as smoothly as possible. We don't want them fighting the tube. Also, it's terrifying when somebody shoves something down your throat. So, you know, we don't want them to be traumatized, but we also need to get it in place. You know, the provider is going to do this in less than like 10 seconds, but we're going to hyperventilate. Usually, we're going to ventilate them good while we're taking them down with the meds, but you can't do that to somebody while they're awake. They'll fight
Okay.
it. There's going to be too much resistance, which causes airway issues. You could cause damage to their airway, their teeth, things
Mm-hmm,
like
mm-hmm.
that.
Yes, so all important things. And so the other thing is you don't want the patient's you know, body fighting against the actual ventilation, right? Being mechanically ventilated, being on the ventilator, because the ventilator is going to now do the work for the lungs. Okay, the ventilator is going to be doing that, the action of expanding, contracting the lungs. So we don't want the patient to waste their energy and you know, be fighting against the ventilator because the outcome is not going to be beneficial for the patient. So that's why we paralyze and sedate the patient so it can go smoothly, just as Erica said. But that's a really important concept. And I don't know how often you see that unless you're like in the ICU or emergency room setting. And that's not necessarily an everyday that you see in the emergency room kind of thing that happens. Okay, anybody have any questions about this one? Okay. And hopefully you saw the word priority and you're like, okay, if I could do one thing, what would it be for this patient? And of course, their airway, if you go with the ABCs. Okay, awesome. Let's go to question number 4. And again, I'm looking at the nurse's notes to see if there's any updates. I'm looking at the lab reports to see if there's any updates. And it looks like there was an update in the nurse's note, right, Erica?
Yes. So at 9:30, almost right away, I'm always talking. The client was intubated with a number 6. So tubes have different sizes. The smaller the tube, the smaller the width. This kiddo would get like a 4. I'm probably like a 6.5. Endotracheal tube was placed on assist control mechanical ventilation. So their ventilator is going to be set a certain way of a respiratory rate of 14, a PEEP of 5, FiO2, so they're getting 60% oxygen. Vital signs. Temperature is 99.8. Heart rate is 110. Ooh, that's pretty high for being intubated and sedate. Okay. Respiratory rate's 14, which is good because they're not fighting it. BP is high, 180/90. It's telling me my patient's probably really uncomfortable. Pulse ox is 96%. Client is restless. Okay. Okay. Makes
Okay,
sense.
so what I like how you kind of thought that through, Eric, and you're like, whoa, something's not quite right. I'm
We need
not
to change
really
something.
sure. Something's happening, right? So now we look at the lab report, that's still the same. So now we have this indicated versus not indicated. So I'm going to let you continue, Erica, if you don't mind.
Okay, we are going to administer sedatives. I didn't realize I shouldn't have some before, but it wasn't in the order. So we need to do sedatives. That'll help bring down a lot of things. We do need to repeat the chest x-ray. I think, yeah, I would repeat the chest x-ray. Schedule suctioning. No, we're not going to schedule suctioning every 2 hours. We're going to keep the patient in mind and listen, and someone will be in there. So that's not indicated. We're not going to administer AMI. It didn't say anything about a cardiac arrhythmia. Typically, we give AMI for cardiac arrest. We're going to give them if they're in VTAC or VFib, or like stable VTAC. But there's no arrhythmia here, so we don't need to worry about that. Administer IV antibiotics. That's going to be indicated because something caused. We're waiting on that sputum culture still, but something caused this respiratory distress. Position supine with head midline. Head's going to be midline usually, but that's not going to be indicated. We need this patient upwards. They're having breathing difficulty. They probably have pneumonia. We need them, at least semi-Fowlers or Fowlers. Obtaining ECG. Yes, we want to know what's going on with this patient's heart.
Okay, excellent. All right. So I agree with pretty much everything that you said. And I would say that this patient probably need to definitely be in the Fowlers, or even the prone position, because we prone our respiratory patients, and we learned that right with COVID, for postural drainage, for helping with full expansion of their lungs. So definitely at least the semi-Fowlers and maybe even the high Fowlers position, but not supine. Okay, not supine at all. Okay, let me pause here to see if anybody has any questions, or you're like, this doesn't make sense, or let me get some feedback from the group. Okay, let me call someone. Ethan, what do you think?
I agree with everything. The only thing I'm unsure is about the antibiotics. Why that was indicated.
Ah, okay. So that's a really great question. Okay. So let's take a look at the labs and see what's going on. So the blood culture right now says that it's that the results show a gram-negative cocci. So this tells me that they have a gram-negative infection. Okay, they have a gram-negative infection. And so I'm glad that you asked that question, because this is why looking at the lab results kind of like line by line and saying, okay, what's normal, what's abnormal in this patient? And if you had like a little whiteboard or a scrap piece of paper, I would write down the abnormal things because those are things that I'm going to have to do something about, or those are some things that some action is going to have to be taken. And so in this case, and you can see, I just want to annotate that, okay, this is not a normal finding, okay? And we want it to be negative, but they are positive in their blood culture. Does that help, Ethan?
Yeah.
Okay, now
I think it was just like a lot of information. I just kind of missed it. I didn't write it down. And
yeah, no, and that's okay. This is like really extensive. This is like a full clinical day. Like this one question is a full clinical day. And so what I would submit to you is when you all are in clinicals, I want you to start thinking like, okay, this is a next generation NCLEX question. Okay, so when you are looking at the patient's chart, when you're receiving report, as the patient progresses, you do your nurse's notes, right? This is totally what your clinical day will look like. Okay, so and again, I like the results because the lab report because it gives the patient's results and then it gives you the reference range. And that is helpful. So even if you don't know what the heck is going on with your patient, one thing that you could always do is, okay, which ones are not normal? And which ones are not within the reference range, and just kind of circle those or highlight it or make a note, because that's going to help you think about what's happening with the patient. Okay. So thank you for that, Ethan. Let me go to Kathy. Kathy, what are you thinking?
I agree with Erica.
Okay. All right. Fantastic. All right, Crystal, what are you thinking?
I'm just taking it all in. This is a lot. I've never done something like this before.
Okay, all right. Yes, understood, understood. And I know that a couple of students have kind of gone through this with me before, and it can be shocking the first time, but I guarantee you, the more of these you do, the more comfortable you're going to become.
Right.
Okay. All right. And it's better that you get shocked now and acclimated, because this is what the NCLEX will be like. So I understand that there is an initial shock. Okay. All right. Well, let's go to the next one. And again, I just want to reiterate, any new nurses notes, everything looks the same. Laboratory report is the same, nothing new on that. Now we have something new. We have orders. I will give you a heads up because sometimes the way your questions are set up, it may not be like highlighted in yellow like this. It might be a tab that you have to click. So make sure that you're always looking for new information so you don't miss it. Okay. Erica, would you like to continue, please?
Sure. So they broke it down into 3 categories: nursing, medications, and monitoring. I'm going to read them first, then I'll go through, I guess. So insert urinary catheter. It's going to be important, but not necessary immediately. Suction, the tube is needed. Again, that's maintenance. Titrate oxygen to keep it. That's maintenance, but you're usually going to call RT for that. They don't like them messing with events. Start IV of normal saline. I didn't know we had to have an IV. We are aside. Okay. Amoxicillin, IV piggyback. Midazolam. Okay, first and foremost, we're going to go ahead and give them midazolam because that's our sedative. We need to do that. Sorry, just going through.
Okay, so you want me to
Tylenol.
highlight that?
Yeah,
Okay.
that would be the very first thing I did. Okay,
Okay.
Tylenol. Okay, fine, whatever. Perform 12 lead. We need to do that at some point. Call for chest x-ray. They just dropped that tube. Gold standard in the hospital is going to be to get an x-ray to confirm placement.
Okay, so you want me to select that?
Blood gas in 30 minutes. That's not a priority. So now we have to pick one more.
Okay, I'm going to stop you, Erica, and I'm going to ask the group. Erica has chosen 2 things, and she says that there's one more. What would you choose? We're talking about the top 3 things to do for this patient based on these new orders. All right, I'm going to go to Ethan. Ethan, you're the gentleman of the hour. What do you think?
Um,
And it's okay if you're wrong. It's okay. I will not hold it against you. I will not judge you and I will not think any less of you. And I don't think your classmates will either.
Is it the IV of normal saline?
Okay. Why did you think that, Ethan? Because it is correct.
I'm not sure.
Okay, that's okay. So you guessed well.
I think
Okay.
because this patient's not going to be taking anything in right now. They're sedated.
Okay, so they're sedated. And so what is this normal saline? So whenever you choose something that you have to implement for your patient, okay, why am I doing it? What is the outcome? What is the expected outcome going to be? Okay, so having an IV, any patient that is admitted to the hospital should have an IV because we want to have a patent IV in case we need to quickly administer any medications. And we know that this patient is going to receive IV antibiotics. So that's going to be really important. So we have that IV access that's patent, it's open, and whenever that medication is going to be given, it's ready to go.
So
Okay.
I have a question about this.
Mm-hmm.
We are aside earlier why the patient would have had an IV.
Well, I don't know if the order said to do it. Let me
Okay.
see. So the patient, so at 9:30 was intubated, and what does it say? So they had an IV, but they didn't have any fluids running.
Okay, so we do need to run fluids, especially if we're pushing the Versed. So
Okay.
yeah, okay.
Okay,
Okay.
yes. And so that's a great question. And so sometimes when we go through these questions, because it's a lot of information to take in, we kind of have to break it down and say, okay, maybe I missed something. Let me go back and look at it. And that's totally okay to do that. Okay. And I will tell you, as I've started to go through these questions myself, I'm like, man, I remember the first couple times I was like, man, I'm missing these. Let me go back. And I wasn't taking my time. I wasn't breaking it down like how Erica is breaking it down. I really wasn't doing that. I was just kind of going really fast. I'm like, okay, and I missed some new stuff, the new notes and everything. So that's why I keep reminding you because I know that these are the mistakes that I made, you could possibly make as well. And I don't want you to make those mistakes. Okay. All right. So these are the 3 things that the nurse should implement first. And this is a priority. Okay. So this is kind of neat because again, if you're in clinical and you have a scenario, something like this, I want you to think about it. And I want you to bring it up to your clinical instructor and say, okay, what would you do? Or can you tell me why? Because that's going to help you when you see it in action. Okay. Anybody else have any questions or comments? Okay, we're going to go to the next question then. So this is question 6 of 6. Okay, so again, I'm going to look for the nurse's notes. Is there anything new here?
Yeah,
And
1000.
yeah, it is. And I'm going to blow it up so you can kind of take it in. And again, I missed the notes a couple times when I was doing these questions. So that's why I keep saying the same thing. So in your mind, you're going to have a little voice saying, check the notes, check the lab results, anything new, right? So you won't miss it. Okay, go ahead, Erica.
Okay, so at 1000, our CXR was obtained, IV placed, and midazolam given. EKG shows sinus tach. Oh, she's still tachy. Vital signs, temp has not changed. Heart rate is 100. Okay, it came down a little bit. Respiratory rate still 14, which makes sense. She's on a vent. BP 150 over 70. That got better. Pulse ox got worse. Okay, 93%. FiO2 is unchanged at 60. She's drowsy, -1 on the station, which makes sense. We gave her a sedative. So, okay.
Mm-hmm. Okay. Awesome. Okay, I'm going to pause here, and there's a lot to unpack with that 1000 nurses note. Anybody have any questions about any of this? The new stuff. Okay. Lab results. I'm looking at the lab report. Everything is still the same. Okay. So the orders. Okay, here's the orders. There's nursing orders, medication orders, monitoring orders. It's just like the last question. Didn't miss anything. So let's look at what we're doing here. Okay, go ahead, Erica. I'll let you continue.
Okay, her heart rate improved. We dropped from 110 to 100.
Okay, hold on 1 second because the rest of the group may not understand what we're doing. So for all of these things on the left, the heart rate, temp, respiratory rate, blood pressure, pulse ox, and agitation, we are actually saying, did her condition improve or did the patient's condition improve? Did it decline or is it unchanged? And I can make it smaller in case you need to look at the notes. I don't know if I'm going to be able to fit everything on one page. I can't. I'll try to at least fit in the updated stuff. Okay. Can you see the 100 notes and everything else?
Hmm.
Okay. Okay. Anybody have any questions about what this question is asking you before Erica continues? Okay. All right. So Erica, you said the heart rate improved. What did you say about temperature?
Temperature has unchanged. It's still at 99.8.
Mm-hmm.
Respiratory rate is still 14 and it's on the vent. And the vent's probably set, so that's unchanged. It's probably set away where she can't breathe over it or whatever.
Mm-hmm.
Blood pressure did improve. It went down, so we're trending back to normal, so that's good.
Mm-hmm.
Her pulse ox declined, so the nurse needs to either listen to her, suction her, maybe RT needs to come and up the oxygen percentage. We need to do something probably. And her agitation has improved because now she's sedated some.
Okay, yes. Let's talk about this pulse ox. So why is that so concerning to you?
She's on a vent, and vent settings are super, super specific. So her P plus 5, she has a respiratory rate. She shouldn't be going down unless there's something going on. Unless, um, oh gosh, I wish I could remember the acronym. There's an acronym for like obstruction. I think it's DOPE. Displacement, obstruction, P. I don't remember what the P was and E. There's different things that you look for when a patient is tubed. Because if her pulse ox is going down and her adjustments haven't changed, they probably need to up the oxygen or suction out mucus or something. There's no reason her pulse ox should go down when she's got a solid tube in place. The chest x-ray confirmed that, it wasn't that it wasn't, a right main stem or it wasn't anything. So you're going to check anytime the patient has an ET tube for displacement, obstruction, and obstruction could be as simple as mucus. It could be you just
Yep.
need, anything like that. A pneumothorax, which is why you're going to listen. The nurse needs to listen and see if there's decreased sounds. That could be a right main stem, which would go under displacement because the right bronchus is a lot straighter, so you can actually go too far. Equipment is, did the cuff not inflate completely? It didn't say whether the tube was cuffed or uncuffed. The nurse is going to take note. The ET tube has marks on it, and they're usually going to put in their note 25 at the teeth or 26 at the lip. So you're going to check to make sure that there's no equipment failures. It's blown up, it's not moving, and then your stacked breath. So that's really going to give you an idea of, is something wrong here? What can we do to change it? Or do we need to just up the PEEP or the oxygen?
Okay, so excellent. And so those of you who are like, oh my gosh, what is Erica talking about? You have to know. And do all the students know you that are on this call? Do they know your background, that you have a background in
No,
emergency medicine? Like that,
I
that's
know
what you
Brittany
do?
and Ethan, but I do this I probably intubate somebody at least every week, and my patients are on vents sometimes for transports and stuff. So to be fair, this is not something I learned in nursing school, like with this
Okay.
specifically.
Yes, and I want to bring that up because probably some of the students are like, what the heck is going on? Like, how am I supposed to know this? No, you're not
Yeah, I
necessarily
was about to
supposed to
ask
know this.
Erica, does she tutor?
No, so this is what Erica has been doing for a long time, but the level of detail that she's going into is not necessary for where you are right now. But I think the critical thinking that she's displaying, I really love. So that's why we're, kind of having this discussion, right? Because it's taking you to the next level. So for NCLEX, will you have to know dopes? No, but you do need to know that, okay, if my patient that's on a ventilator or that has a tracheostomy, if their pulse ox is going down, I probably need to suction them. That's what you need to know. That's what you need to take away from this, okay? So I know it could be like, oh my gosh, what's going on? But that's what you need to think about. And she was just giving you extra to know, okay, if it's not the suctioning,
A lot of extra, sorry.
right, no, but no, it's great. It's great. But I just wanted to let them know, kind of, reorient them to say, okay, it's okay if you don't know about that. And okay, Erica, she's frequently intubating patients. I have never intubated a patient. Okay. So that's not something that I have done as a nurse. And she's not doing it as a nurse, she's doing it as a paramedic. You're doing it as a paramedic, right?
Yes, and as a flight medic, which also means when I start work in a couple of weeks, I need to watch myself because my scope of practice is going to be very different.
Yes, it will. Okay. So I just want to make sure that we gave you that information, but rein you back in on what you really need to know at this point as a nurse in Med-Surg 1 or Med-Surg 2. Okay. So if you have a question and a patient that is on a ventilator or has a tracheostomy, the two things that you want to look at, okay, after you see that their pulse ox has gone down, I need to assess, I need to auscultate their lung sounds, and I'm probably going to have to suction them. Okay. And those are the two things that you must know at this stage in the game. Okay. Does that help a little bit to kind of allay your anxieties a little bit? Anyone?
Yeah.
Okay, okay, sounds good. All right, let's continue on. All right.
Hold on.
Say,
I have a question about the agitation.
oh, okay.
What?
Okay, let's
Well,
try
my
to.
question was that just based off the fact that she was sedated? Or
Yes, that
okay.
is, yes. And so that's a great question, Ethan. And so this patient is actually drowsy and they're a -1 on the sedation scale. So if they're like drowsy, they're not showing any signs of agitation, if that makes sense. Okay. Does that answer your question, Ethan?
Yes.
Okay, and that was an excellent question. Okay, let's quickly go around the room. Raven, do you have any questions about this scenario and what we did with this one?
No, but I learned a lot.
Okay, fantastic. Let's see, Kathy?
Nope, I've been exposed to this in the hospital setting.
Okay, nice. Okay, and Crystal?
No, I don't have any questions right now.
Okay, awesome. All right, let me see. Okay, thank you, thank you, thank you. All right, let me, I'm gonna stop sharing because I have like a few of these case studies open. Let me go to the one that I wanted for the cardiac scenario. Okay. Give me just a moment. Okay, what did I say we were gonna do? We did the acute respiratory distress and we could do heart failure. Maybe we should do the heart failure.
Is it right-sided or left-sided?
I don't know. Let's see. That's a great question. Okay, let's do the heart failure one. And I like how you're thinking already. Okay, let's see. All right, I'm gonna try to close out some of my tabs. I have way too many tabs, folks. Just give me 1 second, please. Okay, heart failure. So I like how you're thinking with, okay, is it left-sided, right-sided? And kind of talk us through what's the difference between those two?
Right sided. Oh, you go
Go,
ahead.
No,
go,
please.
go ahead, Raven.
Right sided, you want to think lungs.
Wait, right-sided or left-sided?
I guess left sided. I guess I said it wrong.
Okay, okay, yeah, so left lung, so think because they both have L's.
And 4 letters.
Yeah, that's a good way to remember.
And then
Okay.
right, so I just remember 4 and 4.
Okay, all right, good. So tell me what else? Because I'm having difficulties finding this thing. So tell me how this patient is going to present, your heart failure patient.
Trouble. You said it was left side?
I'm not sure which one it is. I'm still trying to find it real quick. So just talk me through right-sided heart failure and left-sided heart failure, what you'll see. You can choose one. Oh, I can't find that one for some reason.
So left-sided, they're gonna have trouble breathing, shortness of breath. They're gonna have edema.
Okay,
I'm sorry, my kids are in the back.
that's okay. They live there. It's okay. Why can't I find the one that I want? Okay.
Their blood pressure it will probably be high. All I can think of right now.
Okay, so that's pretty good. Okay, just give me 1 second, guys, because I can't find the one that I'm looking for whatever reason. Because of course I'm looking for it. That's why.
Is it the pictures?
No, I want to do another case study and I'm trying to find the cardiac one. Okay, chest pain. Okay, I think I found it. Okay. All right, so question 1 of 6. Okay, I'm going to be sharing my screen. So tell me if you can see it. And I'm going to have Raven start us out for this one. And we're not going to leave you hanging, but I want you to kind of walk through this question with us.
I'm a little nervous.
It's okay. This is a safe place. We won't judge you.
I
Okay.
like this one, but I'm gonna keep my mouth shut.
No, it's okay, Erica. I think you add value. Like you are amazing. So I'm glad that you're here.
A 60-year-old male client is admitted to the emergency department with crushing sternal pain radiating down left arm that is worse with walking. Pain began 2 hours ago while walking outside. Client also reports shortness of breath with activity. Reports taking a regular aspirin on the way to the hospital. The vital signs are temperature 99, heart rate 110, respirations 22, blood pressure 160/90, pulse ox 93% on room air, chest pain is at an 8 out of 10, weight is 280, started on chest pain protocol, oxygen applied, and nitroglycerin given. A peripheral intravenous line was placed in the patient's left arm, morphine given, and labs drawn.
Okay, excellent. So what are some of your initial thoughts, Raven, about this patient, this 60-year-old male patient?
The pain down the left arm.
Uh-huh.
He could be having a heart attack.
Yes.
So that's my first thing that I thought about.
Okay, very good. So those are clinical cues. Okay, continue with the diagnostic report, please.
ECG sinus tachycardia rate 110. ST segment elevation in leads is V3 and V4. Interior leads.
Leads. You're right.
Do you want me to go over the labs,
Sure. Why not?
or can we all just look at it.
Look at it. Okay, you all can look at it and I'll talk about it. So the cholesterol is 250. This cholesterol is high. Okay, and so I would expect this finding because I know this is a cardiovascular scenario, right? Because you told us that crushing sternal pain, radiating down the left arm, right? This is all classic, cardiac MI, something is happening. It's pretty significant. The other thing is the patient has this sinus tachycardia. The other thing that's really concerning to me is that they have ST segment elevation. Okay, so if you're ever at clinical and you hear STEMI alert, that's what they're talking about. And the ST, so the PQRST complex, that's what they're talking about, that it's elevated. And I think with one of the med surg groups, I don't remember, we talked about the PQ. Actually, no, that was this morning. I take that back. I did cardiac this morning with the health assessment group. So I didn't do that with you all. But the PQRST complex, are you all familiar with it?
Yes.
Yes, okay, so you understand the significance of the ST segment elevation, okay? All right, so I'm gonna continue and thank you for that feedback. The white blood cells, okay, not really concerned about the white blood cells. Platelets are looking okay for me, within normal range. The potassium is within normal limits. The sodium, normal limits. Magnesium is on the low end, but it's still within normal limits. Troponin, now, I did talk about that today with the group this morning, and I think it was with somebody, I don't remember, but we talked about troponin being the gold standard. Why is troponin the gold standard when we're looking at a patient that may be having a cardiac event? Anybody have any ideas?
It's
It'll tell you that they're having an MI, that is elevated. It's
yeah,
indicative.
it's specific
Yeah, to a MI.
myocardial ischemia.
Yes, that is like super important. So it
I
is
mean, the
the gold standard.
CKMB is high too, but troponin's going to be your gold standard. And they're going to run that as soon as you get there. It takes 10 minutes and then boom.
Mhm. Yes. So that's like super important to know. Okay. So your troponin. So, and even if you don't know the lab values, guess what? It gives you the reference range. And so this 0.5 is way higher than what's normal. Okay. So creatine kinase, that's significantly high too. Okay. So let's now go and I'm just going to take, a poll from the class. You can just shout out what you think I should check. The nurse reviews the diagnostic and laboratory findings. Which two findings are the most significant? Do you think the EKG finding is the most significant?
I think it would be
Yeah.
the EKG and the troponin.
Component.
Okay, EKG and troponin. Everybody agrees?
Yes.
Okay,
Yes,
yes, fantastic. Okay, and you are correct because this EKG that says sinus tachy with ST elevation, ST segment elevation, and then this high troponin level tells us there is actual damage to the cardiac muscle. Okay, very good. All right, let's take a look at question 2. Okay, and so here's the nurse's notes for 10 o'clock. That's going to be the same, and the diagnostic report is the same. The lab values are the same, and I try to do this every time so I don't miss anything. So for each client findings, click to specify whether the finding is consistent with ST elevation MI or non-ST elevation and MI or unstable angina. Okay, unstable angina. Okay, so let's talk about the creatine kinase, MB. Okay, so is this, let me ask, should I check ST elevation myocardial, non-STEMI, or unstable angina, or all three of them?
I'm gonna go with the ST elevation STEMI.
Okay,
I'm going to add NSTEMI too.
you're gonna add N-STEMI, okay?
CKMB, I mean, it is, It's not 100% specific to ST elevation.
Okay,
I've seen a lot of NSTEMIs with a high CKMB.
and that's a cardiac enzyme, right? That tells us that there's damage to the heart muscles as well, right? Okay, so it doesn't have to be a STEMI, or it could be a STEMI or a non-STEMI, but you're right. And that does not go with unstable angina. Okay, good. What about crushing chest pain? Could it be all three?
Yes,
It could be.
absolutely.
Agree.
Yes. Okay, great thinking. All of you are in unison. I love that. So
And
it
they
could,
we didn't point it out, but they already started Mona when they first got there too. And Mona is something we learned about. I don't remember if it was MedSurge 1 or MedSurge 2, but it was a big part like on our test and stuff too. And they already highlighted all of them at the beginning, but we didn't talk about it at all. So I just wanted to mention that because that acronym we did have to know. And I think it was on the cardiac test.
it probably is, and I'm sure it's going to be on the next when they do the order kind of questions. They're probably going to have that, and I'm just putting it in the chat in case someone doesn't know what Mona is. So that's your morphine, your oxygen, your nitroglycerin, and your aspirin. Okay, and he actually took an aspirin when he was on the way in, right? He's like, I already know it's what's going on. I'm going to take my aspirin. Okay, EKG changes. Which one should I choose, or should I choose all of them?
Well, you're gonna choose ST elevation.
You're right, Ethan. Okay. And that's going to be the only one. Okay, that's going to be the only one. Okay. What about elevated cholesterol? So, do you think a patient that has any cardiac issues, they're going to have elevated cholesterol in general?
Yes.
Yes,
So would
they
this gonna be all three?
That's
because of
right.
lifestyle factors.
That's right. Okay. And so that's an expected finding. I expect to find elevated cholesterol because that usually leads to cardiac issues. Okay. All right. Good job. What about obesity?
Would that one again be all three because it goes back to cardiac issues?
Yes. Yes. And I love what Erica said, lifestyle factors, right? Absolutely. Okay. What about troponin?
That's specific to ST elevation.
Not necessarily. You can have it with NSTEMIs too. It just matters what the treatment for them.
Yes. So it's when we have damage to the cardiac muscle, and that could happen in a STEMI or a non-STEMI, you're going to see that troponin that's going to be elevated. And remember what happens, what's physically happening when a patient has an MI, myocardial infarction. The myocardium is the heart muscle. That's the thick layer of the cardiac muscle that is actually the one that's doing the contracting. Infarction is there's a blockage of a blood vessel, so blood cannot get through. So that tissue beyond the blockage is ischemic. And what happens when cells and tissues don't get proper blood flow?
They die.
They die. So literally a part of the heart is dying. Okay, so if you think about it like that, you can be like, man, this is pretty serious. So that's why the patient's troponin levels will be elevated. Okay, and so this is a tough question. Okay, and I think
Is
if you're,
the scoring rule 0 or 1 on this one, or is it plus minus?
it's plus minus. Okay.
Okay.
And that is a great question. So for those of you who may not be familiar with the scoring rule for next generation NCLEX, if you choose something correct, you get a point. If you choose something that's incorrect, you get 1 point subtracted. So you really want to be sure and be very intentional about what you're choosing. Okay. But that's a great question, Erica. All right. Anybody have anything about this question? This was a tough one. if you can follow and understand, you're gonna be in super shape for your test. I'm telling you that right now. Okay, question number 3 then. Okay, I'm gonna check, are any new nurses' notes? It seems that they're all the same. EKG is still the same. Lab values are still the same. Now I have drop downs. The nurse should recognize that the client is most likely experiencing what? A non-ST elevation, MI, an ST elevation, MI, or unstable angina.
ST elevation.
ST elevation, am I?
Okay, I love the way that you all are thinking. Okay, fantastic. Okay, so I'm gonna check ST elevation caused by coronary artery.
Do you want to click the options?
Oh, I'm sorry.
Blockage.
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 Yeah, the left anterior descending artery is blocked here.
Okay, now how do you know that, Erica?
So up there, when it had the EKG, it
Uh-huh.
showed that the ST elevation was in
Ah.
leads 3 and 4.
Yeah,
So,
okay.
and this is hard to understand if you're not like nurses in the ER don't necessarily understand this. Pre-hospital, generally the provider, and even when they get there, you want to know where the elevation is because depending on where the elevation is, tells the when they're going to go in and do your cath, it tells them where they're going to go to open up that blockage. So if you look at your 12 lead, which is what we're doing in this, each section, you can tell where the blockage is based on what leads have the elevation. And when you get a chance to read one, you'll see leads 1, 2, 3, and then you have V1 through V6, and then you have AVL, AVF. And you can actually, an AVR, you can actually look and see exactly where the elevation is. And there's a chart kind of that we memorize / follow. And wherever the elevation is tells us where the blockage is. And then by knowing
Okay.
that, it's either inferior, anteroseptal, anteroapical, anterolateral, or lateral. You can tell if it's the widowmaker, if it's the left.
Okay, Erica, I'm gonna stop you there. I'm gonna stop you there because so that's interesting. And I was asking the question just because I wanted to know, but for what we need to know here for what this group, they don't need to know that part of it, but they do need to know ST elevation and the blockage. And I feel pretty confident that they understand that part. Okay, but I appreciate it. Erica, I'm gonna have to take you out for coffee. All right, let's continue. Okay. So this is question 4. Again, nurse's notes still look like nothing's new. Diagnostic report, nothing's new. Lab report, nothing new. So the client receives a diagnosis of ST elevation, MI. So you all are right on it. Okay, you're right on it. So now you're going to look for each potential medication order, click whether it's indicated or not indicated. And sorry for that typo, but it should be indicated and not indicated. Okay, so tell me what you all think for analgesics, indicated or not indicated? Kathy, what do you think?
Well, he got Mona, but that's not an analgesic. That's something else.
So
I'm gonna
let me,
say, okay, so I'm thinking about the Mona. I know he
Uh-huh.
got morphine.
do you think this patient is in a lot of pain right now?
He probably is.
Okay,
I'm sure.
so based on that, do you think that they should get analgesics or not?
Yeah.
Okay, so I'm gonna say indicated. Okay, do you agree with that? Indicated?
Yep.
Yes. Okay, Ethan says yes. Raven, what do you say?
For the antibiotics?
For analgesics, and then you can tell me
Oh,
antibiotics too.
I say indicated.
Okay, good. Okay, what about antibiotics, Raven?
I say no. They don't have an
Is-
infection.
Okay, good. Okay, and Ethan, what do you say about anticoagulants?
Indicated? I think.
Mhm.
Okay, so you are kind of sure, but Miss Kathy, tell us why we should give anticoagulants.
Because like Erica said, he has a blockage, so we want to try to break down that clot or
Okay,
that blockage.
okay, great. Okay, Erica, what about beta blockers? Is it indicated or non-indicated?
He was tacky, I believe, so it would be indicated.
Okay, excellent. Okay, fluid bolus. Anybody want to volunteer for that one?
What was his pressure?
Okay,
His
great
pressure was
question.
elevated. His pressure was up. It was 160/90. No, I wouldn't give him a fluid bolus. Not
agree.
with a pressure like that, I wouldn't.
Okay, I agree with you. And so kind of walk us through why you don't want, well, tell us what is a fluid bolus, first of all, and then why you wouldn't give it to this patient with an elevated blood pressure like that.
So you're adding more fluid onto the body. The heart is already in trouble. That means the heart's going to have to beat faster to get that fluid through the body. So why would you put extra work on the heart? Because
Okay,
it's already in trouble.
absolutely. Okay, so excellent thinking. And the fluid bolus, you're giving a large amount of fluid in a small amount of time. And so we don't want that for this patient. You're absolutely right. What about fibrinolytics?
That one, I can't remember about that one. God, I can't remember.
Okay, anybody could answer. Anybody have any ideas?
Indicated.
Okay, so you say indicated, and that's correct. And why do you say they're indicated, Ethan?
Because those prevent and break up clots.
Yes, that's right. They will dissolve any clots. Okay, the anticoagulants will prevent, but the fibrinolytics will bust up the clot. Sometimes your fibrinolytics are called clot busters, not only for your cardiac patients, for like your stroke, your CVA patients, right? Okay, or sorry, I should say thrombolytics, but they're going to dissolve any obstructions. Okay, any
Right, so
questions?
yeah, so just anticoagulants is for like preventing clots, and then fibrolytics is for like dissolving them.
That is correct.
Okay.
Okay, so think prevention, fibrinolytic, they already have clots. Okay. Anybody have any questions on this? Okay, and I know Erica, we're almost to the end. I think you said you had another session at 8. I'm sorry that
I
we're going.
do. Do you mind if I pop over to that one with my
No,
teacher?
yeah, no, that's totally okay. Thank you for being here. We appreciate you. We learned so
Thank
much
you.
from
Sorry
you.
for going too in depth. I like the respiratory and the
No,
cardiac.
it's my fault because I asked you because I love it too. So, but I think we kind of reined it back and told them, hey, they don't have to know that stuff. So
My
I think
bad.
it's good. I hopefully we didn't harm anything, but appreciate you, Erica, so much. I'll see you next
Thank you so
time.
much.
Okay, you're welcome. Okay. All right, let's look at question number 5. Okay, so I'm still sharing my screen. We're talking about the 60-year-old male. I'm looking at the notes. Nothing has changed. The diagnostic report's the same. The lab report is the same. The orders, now we have orders here, okay? So we have orders for enoxaparin, metoprolol, tenecteplase, and morphine sulfate. So what's going on with these orders? Okay, so the nurse receives the orders, complete the sentence from the list of drop down options. The nurse should next give the enoxaparin, the metoprolol, or the tenecteplase. Which one should the nurse give first?
I know the Levinox is for prevent clots.
Mm-hmm.
The metoprolol is going to help with his heart rate, and it can help with his blood pressure.
Mm-hmm.
That last one is a clot buster, right? The
Yes,
paste?
yes, the fibrinolytic. That's correct.
Ah,
Would you want his, I'm just guessing. But would you want blood pressure come down first?
Okay, so let me ask you this question. Okay, so I understand you want the blood pressure to come down. If you get the blood pressure down or you try to administer the blood pressure medication to bring the blood pressure down, if there is still a clot, still a blockage, will that blood pressure medicine work?
What?
No,
Yes.
no.
Okay.
So give I'm thinking the clot buster first.
Yes, because that is actually the problem. That is going to help because once that blockage is opened up, that should help everything else. Okay, that should help the blood pressure, that should help the heart rate, and hopefully the patient won't have any more damage to the heart muscle itself. Okay, and this medication you may not be familiar with, but I'm going to let you see the choices so you can see should it be given immediately upon admission, within 30 minutes of admission, or within 90 minutes.
I'm gonna say within, that clot buster should be given as soon as they get there, after they get the lab results.
Okay. So what is your choice? Is it upon admission, within 30 minutes of admission?
I'm gonna
Or-
go with the within 30 minutes. I was thinking immediately, but I'm gonna go with 30 minutes. I don't know. I may be
Okay,
wrong.
well, you're actually correct, Miss Kathy. So you had great thinking because we're not gonna be able to give it immediately because we've got to get some of those lab results first. We have to figure out what's going on with the patient, so before we can actually give that medication. Okay, awesome, awesome, awesome. Okay, anybody have any questions about this? This is a drop down kind of question. Okay, let's go to the last one. Okay, so I'm looking again to see any nurses' notes. I see that at 10:25 we got the orders and the Tenecteplase was given, so that's good. And at 10:30, now I'm looking at the vital signs. Okay, and observe the vital signs. The temperature is still slightly elevated, heart rate is 120, respiratory is 22, BP 150/85. Pulse ox is 95, 2 liters nasal cannula. The pain is a 6 out of 10. The diagnostics report is still the same. The lab report information is still the same. The medications still the same. Okay, so now I'm going to try to fit everything. It's hard to fit all on one screen. I might have to scroll back and forth so you all can see it. Okay, so this is to assess the patient, right? And if you notice, these questions are kind of like ADPI, right? Because now we're doing our evaluation because we implemented something. We gave the Tenecteplase, right? 50 milligrams IV. So we're assessing the patient after initiating the chest pain protocol and giving Tenecteplase. For each finding, click to specify if the finding indicates the client's status has improved, declined, or is unchanged. Okay, so let's look at.
So the pulse has declined because that went up to 120. It was 110.
Good job.
The
That's
blood,
correct.
the blood pressure improved. It went from 160 to 150 over something.
That's correct.
The pulse ox improved. That went from 93 to 95. The respiration rate, I think it was 22, and I can't remember what it was before. So that was 22, and it's still 22. So that's no change.
Okay, good job.
The pain did improve. It went from 8 to 6.
Okay, that is correct. That is correct. Does anybody need me to scroll back up, or were you all following along?
I was just following along.
Okay, do you kind of understand though how to get this, like if you were doing it on your own?
Yes.
Yes, okay. So it might take a little bit more time, but that's okay, right? Because Miss Kathy did that actually pretty fast. I think I would probably need to go back and forth, right? Okay, so that is the last question for this particular case study. Okay, I'm gonna stop and gonna go around the room and see if anybody has any other specific kinds of questions, or if your brain is totally fried after this experience, I'm going to stop recording.